Good afternoon. My name is Hannah Holt, and my presentation today will be on dyslipidemia. So first we'll define what exactly dyslipidemia is. So dyslipidemia is defined as having an elevated total cholesterol level, having an elevated low-density lipoprotein level or LDL level, and having a reduced or lowered high-density lipoprotein level. So it's having a high LDL and a low HDL, and elevated total cholesterol, or a mixed combination of all of these aspects. So the pathophysiology behind this disease usually is primary causes and secondary causes, and in both cases, cholesterol and triglycerides and lipoproteins are transported in your blood as complexes, and these are both lipids and proteins. These high levels are associated with an increased risk of coronary heart disease. So the clinical picture, a lot of patients will be asymptomatic for many years, but eventually they'll present with signs of chest pain, palpitations, sweating, higher levels of anxiety, shortness of breath, and abdominal pain. So how will you diagnose dyslipidemia in patients? So it's recommended that for adults 20 years of age and older, get a fasting lipoprotein profile a minimum of every 5 years. So to determine, you do two determinations. The recommended is between 1 and 8 weeks, 2 different labs. And then if your total cholesterol is greater than 200, they'll diagnose you with dyslipidemia. Also, they'll do a history and physical to determine any additional cardiovascular risk factors that you have, as well as any familial history of cardiovascular issues or dyslipidemia. So the treatment, so we have both pharmacological treatment options and non-pharmacological treatment options. We want to recommend both to the patients. The goal of the treatment and both therapies is going to be to lower your total cholesterol level and lower your LDL levels and reduce your risk for complications that are associated with high and dyslipidemia. These complications can be MI, heart failure, and peripheral artery disease. So the goal of treatment is to reduce our risk for these. So some non-pharmacological options that we provide our patients would be for lifestyle changes. And these are going to be diet, having diets that have the appropriate amounts of saturated fats. Weight therapy, have our patients maintain an appropriate weight for their height and age. Increased physical activity, and including a fish oil supplement. So 2 pharmacological options that I'm going to discuss. The first is going to be HMG coenzyme A reductase inhibitors. So these are your statins, for example, atorvastatin. So the way that these work is they inhibit HMG coenzyme A from converting. These are going to be the most potent for reducing your total and your LDL levels. And when combined with diet therapy, they'll reduce your levels by 30%. The second are going to be fibric acids. These are phenofibrates. They're going to reduce your VLDL levels, but also could have a reverse effect and cause a slight rise in your LDL. Most common side effects with this one are going to be GI complaints, rash, dizziness. This may extend the effects of your oral anticoagulants. So an INR also needs to be monitored on patients taking these medications. Thank you.